Respected everyone, topic of my presentation is to assess the role of urologist in management of urological injuries during obs and gynecological procedures. Unit tract injury complicates an estimated 0.1 to 1.5% of all gynecological procedures and cesarean sections. Unit tract injuries due to obs and gynae surgery divided into mainly acute and chronic complications. Acute are identified immediately, which mainly includes bladder and ureteric laceration, while chronic complications include VVF ureteric strictures, which are diagnosed early. Ureteric injuries are difficult to diagnose intraoperatively, particularly during emergency obs surgery, and it is important because ureteric injury early detection treatment prevents renal function deterioration. Simple hysterectomy is the most common procedure leading to such mishappenings. Materials and method study. It is a retrospective observational analysis of 10 years data collected from Grant Government Medical College, which mainly investigates the urological complications during the obs and gynecological surgery. The data mainly includes details of the procedure, type of injury, time of injury, the location of injury, treatment, and the outcomes. Total surgeries were performed on 13,296, out of which unit tract injuries were seen in 72 cases, of which incidence was 0.18% over the period of 10 years. Common age group was 20 to 60 years, and most common surgery associated with this injuries were simple hysterectomy, which was 20 out of 613 cases. Unit tract injuries were 72, out of which bladder injuries were 53 and ureteric injuries were 16, and combined injuries were just 3. Most common primary pathology associated with the bladder injury is uterine leiomyoma, which is present in 45% of the cases, while C-sections includes 18% of the cases. Ureteric injuries are mainly associated with the cervical cancer, which constitute 50%, while uterine myoma 37.5%. Combined bladder and uterine injuries, 2 cases have uterine leiomyoma and 1 case was related to C-section. The radical hysterectomy accounted for 2.6%, while vaginal hysterectomy 2%, while emergency anesthesia 0.04% of the injuries. Total bladder injuries were 53, out of which intraoperatively 43 were diagnosed and repaired with 100% success rate, while 10 cases were diagnosed within 4 weeks, for which modified opener repair was done after a period of 3 months from primary surgery. In that cases, perurethral catheter and suprapubic catheter were removed after 14 days and 4 weeks respectively after a cystographic confirmation. Total ureteric injuries were 16, out of which 10 were left side and 6 were right side. Most common site of injury was distal 3 cm of the ureter. These are the images showing the intro of VVF, which are in the image B. We can see that there is a view which shows the VVF, and image C showing the VVF prepared by the modified opener technique, while in the image D, cystogram was done during the follow-up showing no contrast extravasation of fistula. Time of diagnosis, intraoperatively 6 ureteric injuries were identified, for which ureteroneocystostomy was done with 100% success rate, and within 4 weeks of primary surgery, there were total 4 cases, out of which 3 cases were diagnosed having laceration, for which DJ stenting was done. Out of them, 1 developed ureterovaginal fistula after DJ stenting, and 2 cases where DJ stenting was not possible. All the 3 patients underwent ureteroneocystostomy with 100% successful rate. Within 4 weeks, 1 patient with a solitary functioning kidney and urea developed post-ureteric ligation within 24 hours post-surgery, for which re-exploration and ureteric ring plantation was done over a DJ stent. These are the images showing the different. In the image 1, we can see the contrast extravasation during the RGP confirming the lower ureteric injury, while in image B there is a lower ureteric injury which is being managed over a DJ stent by ureteroneocystostomy. Image C showing the mid-ureteric injury being managed by ureteroureterostomy over a DJ stent. More than 4 weeks of injuries, there were 2 cases of ligatives and 4 had complete transaction. Ureteroureterostomy was done in 2 cases having mid-ureteric injuries, and 4 cases underwent ureteroneocystostomy with injuries at the level of VUSA. Out of 16 patients of ureteric injury, 14 patients underwent ureteroneocystostomy on DJ stent and 2 underwent ureteroureterostomy. Patients were followed up after 3 months for DJ removal with RGP, and if there was no extravasation stricture contrast draining well and no dilated pelvic calyceal system, DJ stents were removed, and patients were to be followed up after 3 months with routine investigation, ultrasound KUB or CT IVU. While the 3 cases of ureteric bladder injuries were identified simultaneously and treated with primary bladder repair, ureteroneocystostomy with a 100% success rate. These are the different tables. Table 1 showing distribution of type and primary pathology of injuries. These are the operative procedures which were mainly done in the gynecological department, out of which elective LSCs were 21,992, and they were out of which 229 were converted to simple hysterectomy. In the emergency LSCs were 11,932, out of which 397 were converted to simple hysterectomy, and there were 9 injuries seen in the converted cases of emergency LSCs. While simple abdominal hysterectomy was 741, out of which 626 were converted from LSCs, and in 15 cases there were ureteric injury was seen. This is a table showing the type of repair done in the different type of injuries. In the bladder injury, which was identified immediately, primary repair was done, and which was done in 43 cases, while in the delayed modified hook was done in 10 cases. Follow-up was done for the first 2 years with periodic clinical evaluation every 3 monthly with periodic CBC, RFT and other routine investigation. Radiologically, we done ultrasound KUB or CT IUB with every 3 months. Predisposing factors were, now discussion part, predisposing factor leading to these injuries were distortion of the pelvic anatomy with destruction of planes of dissection by infection, endometriosis, direct extension of disease as in chronic pelvic inflammatory disease, radiation fibrosis or cancer. Ozdemir et al. Has done on studies on 25,998 cases, out of which there were 63 urological injuries which were similar to our study with incidence of 0.1% in our case. Lee et al. Most common urological injury was bladder injury, 71.1%, while in our study bladder injury was seen 73.6%, with ureteric injuries 22.2%. In Lee et al. Study, most common indication associated with bladder injury was uterine leiomyoma, while ureteric injury was cervical cancer, which corroborated with our study. Uterine leiomyoma in bladder injury was seen in 45% of the cases. Shirley et al. The side of ureteric injury was more common on the left side, while same in our study was 62.5%. In Lee et al. Most common open surgery associated with urological injuries was radical hysterectomy, while in our study simple abdominal hysterectomy accounted for 3.19%. Routine practice to place disease stent prior to pelvic surgery in patient with history of previous pelvic surgery or when there is suspicion of pelvic adhesion. Identification of the ureter was easier. Our study had no case of preoperative disease stent. T. Vizaya et al. Ureter stenting is a choice in ureteric laceration. In failed disease stenting.
Thank you. Your time is finished. Can you just tell that what was the intention of this study? It is because the title you have given is to assess role of urologist in management of urological injuries during obstetrics and gynecological procedure. So, that was the intention. You wanted to assess the role of urologist. So, what is your conclusion about the role of urologist? Because your title and conclusion doesn't match. This is an analysis of the help or surgery done by urologist. Role of urologist is undoubtedly there from multi-million years. So you wanted to prove that there is a definite role. What is your conclusion of the study?
Sir, conclusion is that there are many different institutes and colleges where there is no urologist available, and there are mainly general surgeons. In tertiary level, there are urologists available, and they provide great help in the majority of the cases in simple hysterectomy or radical hysterectomy. So, role of urologist is must in case of every institute or college. So, there should be at least urology department in every college or institute for greater assistance. As majority of the cases happens in gynecology and OBS department, there are lots and lots of cases, and burden is huge. So, there must be a urology department in every college at least.
Thank you.
Very simple question. what is the method of data keeping in your institute? How did you get hold of such large records, 32,000 cases? So can you tell us how is it done through some audit processes, or is it done by electronic records, or what?
So there are written records available in the OT department and MRD sections also, and we collected data from the resident available in the gynae department. With previous record, we are easily able to get that.
Thank you. Now we invite Dr. Sushil Bhatt.